Great. Okay, so I see the note that we are live on YouTube, and so we will get started this morning. Happy Tuesday, everyone. This is the Health Coverage Insurance and Financial Services Committee, and we have a briefing this morning from a stakeholder group that met over the interim, and then we will turn our attention to a couple of work sessions. Then we will likely take a lunch break and some time for meeting with our respective caucuses and return for a couple more work sessions after lunch. So that's our plan for the day. We'll get started with committee introductions, and I will start with Representative Connor. It's nice to see you this morning, Representative Connor. Go ahead.
Thank you, Madam Chair. Good morning. My name is John Connor, and I represent the good folks of part of Lewiston.
Thanks. And just for the public who may be watching, a number of our legislators do serve on multiple committees, myself included, and Representative Connor included. So we try and divide our time, but it's difficult to be in two places at once. So we appreciate seeing you this morning. Representative Arford, go ahead.
Thank you, Madam Chair. Good morning, everyone. My name is Representative Poppy Arford, and I represent District 49, which is the western part of Brunswick.
And Representative Evans.
Thank you and good morning. I am Representative Richard Evans. I represent House District 120, including the towns of Atkinson, Brownville, Dover, Foxcroft, Medford, Milo, Plantation, Lakeview, and Ornerville Township.
Representative Blyer.
Thank you, Madam Chair. Good morning, everyone. My name is Mark Blyer. I represent District 22, which is Leamington and part of Buxton, Standish, and Limerick.
Everyone just jumped around on my screen. Representative Melorano, go ahead.
Thank you. My name is Gina Melorano. I represent House District 62, and that's part of Auburn.
Representative Morris.
Good morning. I'm Representative Joshua Morris. I represent House District 75, which is Turner, Leeds, and part of Livermore.
Representative Tepler.
Good morning. My name is Denise Tepler. I represent House District number 54, which is all of my favorite town of Topsom. And I serve as co-chair, House chair of the committee.
Great. And Representative Matheson is just in time to introduce herself. Go ahead.
Good morning, everybody. Sorry for my tardiness. My name is Christy Matheson. I represent District 1 in Kittery.
Great. And I'm Senator Heather Sanborn. I represent Senate District 28, which is half of Portland and half of Westbrook. And we're assisted today by our committee clerk, Edna Caford, and Colleen McCarthy-Reed, our analyst from the OPLA office. And we are going to start today with a briefing from a stakeholder group that met on LD 1196 over the summer, or I guess it was the summer. It was the fall, I think. And I am just opening up the participants list here. There we go. So I think we will be hearing from Representative Zager, and I will move him into the panel. And I think, are we also hearing from Mr. Moran, Colleen?
I believe so. Mr. Moran, Mr. McLean, I think, was going to briefly introduce things, and then also Mallory Shaughnessy is going to follow up, I believe, at the end and brief you on some of the work of their behavioral health subcommittee.
Okay, great. So it's a bit unusual for us, but I'm going to move all of those people that we mentioned in at once.
Yeah.
And then we'll have everybody there. Representative Morris, go ahead.
Yes, thank you, Madam Chair. And also, Representative Quint is calling in, and I believe her number is in the attendees
Sure, I see it.
place. So I just may want to add that in.
I just pulled her over. So
okay, thank you.
Great. Excellent. Okay, Thanks for letting us know that, Representative Morris. And so with that, I think Representative Zager, I will turn it over to you to quarterback the presentation this morning.
Thank you so much, Madam Chair. I think I want to just be very respectful of the committee's time, turn it over to Andy McLean, who is heads the Maine Medical Association. He'll make some descriptive introductory remarks. I'll make my own brief remarks, and then Mallory Shaughnessy will discuss as well.
Mr. McLean, are you there?
How's that?
Much better. Now we can hear you. We cannot see you, but that's fine if you don't have that.
Oh, heck. How do I?
Mr. McLean, you can click a yes.
My apologies. I'm not a Zoom newbie, but I apparently am new to the committee process. Thanks for your patience. So once again, good morning, Senator Sanborn, Representative Tepler, and members of the committee. I am Andy McLean. I'm the CEO of the Maine Medical Association, and I'm pleased to kick off this presentation of the LD 1196 stakeholder group report. I wanted to express MMA's appreciation for the opportunity to convene this stakeholder group for a critical conversation about the importance of primary care and behavioral health care in our evolving healthcare system. I want to thank Representative Zager for his leadership on this issue and commitment to the process. Also to MMA board member and family physician, Dr. Elizabeth Wilson, who chaired the stakeholder group, and to my MMA colleagues, Dan Morin and Sarah Lepoff, who handled the administrative tasks of this process. We conclude this stakeholder group process with renewed respect for the excellent work of your legislative staff, because managing a stakeholder group process like this is not an easy task, even when the policy work to be tackled is less challenging than it was in this particular case. You will see that while consensus eluded the stakeholder group, I do think that this report will inform the committees and the stakeholders' continuing dialogue about this important topic. Dr. Wilson sends her regrets. She was not able to participate this morning, but expects to join your work session. And with that, I will turn it back over to Representative Zager and then next to Mallory Shaughnessy. Thanks so much.
Thank you so much, Mr. McLean. I want to thank the chairs, Senator Sanborn and Representative Tepler, as well as the entire committee. For the record, I'm Representative Sam Zager, the bill's sponsor. I very much appreciate the attention that LDS 1196 has received so far, as well as the work of the many stakeholders who participated in the meetings this past September to December. The Maine Medical Association, more specifically, as you just heard from Andy McLean, Dan Moore and Sarah Lepoff and others, really rose to the occasion, challenge of hosting the stakeholder series. I plan to use only a fraction of my allotted time and will make 4 points. The final one includes a suggested path forward. The stakeholders considered the equivalent of thousands of pages of relevant studies and reports and compiled a 179-page document, which you've all received. Distilling it down even further to just 12 pages. Dr. Beth Wilson, as you just heard, board member and physician, did a phenomenal job as chair of the stakeholder group. She was fair, level-headed, and committed to a process that would help this committee. Point 1, There are big problems with Maine's overall health outcomes, and so inaction would harm Mainers. For instance, we're living 3 to 5 years shorter lives at over twice the cost per capita than other places in terms of healthcare spending. Maine also has more than its share of suffering from mental and behavioral health conditions, including opioid use disorder, among many others. Point 2, there are problems with Maine's system of healthcare. Since this committee's work session on the bill last spring, the National Academies of Science, Engineering, and Medicine, essentially the nation's top panel of scientists and technical experts from all different fields. These are not primary care oriented people per se. They pointed out, though, that primary care is the only healthcare component where an increased supply is associated with better population health and more equitable outcomes. Still, this national committee pointed out, Maine in particular has no county that meets the needs of the population regarding the availability of primary care. Moreover, the proportion of physicians in training, nurse practitioners, and physician assistants entering primary care has decreased in recent years. For mental and behavioral health, we have a severe lack of infrastructure and personnel at all levels of acuity, from people who present with primary care treatable mental health conditions, all the way up to the most severe cases requiring psychiatric hospitalization. And Ms. Shaughnessy will present a useful model, a pyramid-shaped model, elaborating on that. There are mental health concerns deeply woven into the opioid epidemic and COVID pandemic, of course. Point 3, despite these urgent problems with regard to the relative amount we in Maine invest in primary care, no consensus among the stakeholders was reached. Why not? The findings on pages 7 to 9 of the report convey the key discussion points, and of all the work, that's probably the most the quickest summary of all those proceedings. For instance, some stakeholders opposed any provision that would increase costs, even temporarily. Other stakeholders oppose any provision that would decrease costs or even slow the growth of costs. As you can imagine, since some folks would not budge from their original positions, and everyone came to this in good faith, I believe, but the group deadlocked on primary care relative investment. Point 4, I believe this committee can still advance some meaningful provisions pertaining to the integration of primary care and behavioral mental health. And these are ideas that were part of this legislation at its beginning, but were elaborated and elucidated more during the stakeholder process. So this committee might consider striking the current bill and replacing it with the following 3 provisions. The first is that mental and behavioral health regards mental and behavioral health investment measurement. The Maine Quality Forum already reports to this committee annually on the relative investment in primary care pursuant to Public Law Chapter 244. But we don't have the corresponding data for mental health. This is in fact done elsewhere, both primary care and mental health. So we don't have to reinvent the methodological wheel. And in fact, Karen Lee Harrington told the other stakeholders that the Maine Quality Forum has a really good starting point to begin this valuable work. So that's the first provision that I'm proposing. The second provision the other 2 essentially would facilitate the integration of primary care and behavioral health. One way is to eliminate the need for outpatient primary care practices or outpatient practices generally to apply for a behavioral health license in order to get the higher reimbursement rates that behavioral health only practices receive. So in essence, in my primary care practice, we used to have integrated behavioral health people because we know that that's good care. It's good care for all sorts of things, to have a so-called warm handoff. But the system makes that really hard. And so this would be one way. This is something that the stakeholder subgroup on behavioral health came up with or pointed out. Mallory Shaughnessy, the director of the Alliance of Addiction, director of the Alliance for Addiction and Mental Health Services, was indeed a very important member of the stakeholder group. She was a member of the behavioral health subgroup that made this recommendation and can speak more about it in a moment. And lastly, the other way to facilitate behavioral health and primary care integration is to eliminate commercial insurance carve-outs for behavioral health billing and credentialing. The behavioral health subgroup pointed out that this situation creates the need for additional non-clinical personnel, processes, and relationships. In other words, more people, more cost, not actually more care. That can be eliminated or reduced. The net result, if we don't do something about that, is continued, fractured, less integrated primary care and behavioral health. So again, I thank this committee, I thank the Maine Medical Association and all of the stakeholders.
Representative Tepler, do you have a question for Representative Zager? Go ahead.
Yes, thank you, Madam Chair. And thank you for being here, Representative Zager, Dr. Representative Zager. I was wondering if we have a written version of your comments so that we can use them for our knowledge for the future. Thank you.
Certainly, I'm happy to provide that to the committee. I did advance a slide or forward a slide, which really gets at those three recommendations that might be helpful for our discussions, or just at least the review of the committee right now.
Thank you.
And that's what's on our screen now. Colleen has screen shared that slide, which is what Representative Zager just described. So thank you for that, Representative Zager.
Thank you. I appreciate the question, Representative Tepler.
Great. Okay. Are there any additional questions for Representative Zager? All right, seeing none, Representative Zager was, or Ms. Shaughnessy's comments going to be next? Yes, okay,
Yes.
Great. Ms. Shaughnessy, go ahead.
Hey, excuse me, can everybody hear me okay? I've been having trouble with my headphones. All right, perfect. So good morning, Senator Sanborn, Representative Tepler, and members of the committee. I am Mallory Shaughnessy and the Executive Director, as was mentioned, of the Alliance for Addiction and Mental Health Services. We are the statewide association of treatment providers of these services within Maine's safety net of care. And so those of us within the behavioral health leadership of the stakeholder group did meet and reviewed and assessed policy changes that could be part of the recommendation of this work group. I believe within the full final report that you have at hand is our full report back to you. So I'm going to just do some highlights out of it. We were looking for policy changes that would not only reduce costs and improve access, but meet 4 criteria of addressing the workforce shortage that we have in behavioral health in Maine, reduce this value-free administrative costs and barriers that we have set up for behavioral health care, broaden access to behavioral health services, and improve overall medical and behavioral health costs, outcomes, and experience of the patients, providers, and teams doing the care. So we, yeah, I'm going to sort of skip a little bit. I did submit some things in writing. Representative Dr. Zager has highlighted some of those pieces already. But, you know, it is clear.
Do you want me to pull up your presentation as you're going through it? I could do that if you'd like.
No, that's okay. I am going to reference a couple things in the final report that Dr. Zager mentioned, Representative Zager mentioned. But, you know, clearly when we're discussing healthcare cost drivers, we first have to acknowledge that research has clearly shown that persons with untreated mental health diagnoses have overall healthcare costs that are more than twice as high as those who are mentally well. It is a huge cost driver within the system of care. We do believe, as our subgroup, that adequate pay and benefits for behavioral health services is one of the major contributors to behavioral health workforce and access issues. But we also agree that over the years, we have built up this administrative paperwork and processes that eat up staff time and place a financial burden on agencies and providers. And that also, in effect, limits their capacity to pay adequate wages to clinical and support staff, and reduces the ability to treat people in more rural areas of the state. And lack of access to these services is increasing our overall health costs across Maine, without doubt. We did wholeheartedly concur with the consensus, as Representative Zagar mentioned, of collecting data and measuring behavioral health spending as we've done in the past for primary care. We think that that could provide that solid baseline that we need. But then to the policy recommendations, you know, to the first one, there's 4 that we mentioned. I think Representative Zagar highlighted a couple of them. But to complete the behavioral health reimbursement rate analysis and recommendations that DHHS has undertaken, we believe that that's a critical piece that has to be done by the end of this year for behavioral health due to the stagnant and rates that are just not meeting the needs. But the 3 other changes, I would put them in one mass together. I think Dr. Zagar highlighted one of them, but 3 other changes that we would recommend really need to be done in combination, because doing 1 or 2 without the others will end up kind of popping the balloon in different places and may have unintended consequences that would make the system even more inequitable than it is currently, and continue to impact access to care and cost of care. So I could speak more to that a little bit later, but we would recommend that we eliminate the need for outpatient medical practices, as Dr. Zager said, to have to be licensed as mental health facilities. They have credentialed providers that are doing work within the scope of their practice. They should not have to be jumping through different administrative burdensome hoops that medical providers do not. We also feel that the Maine Care carve-out review process conducted through Maine Care's Administrative Services Organization currently. Yes.
Can you speak just to take that first recommendation or the second recommendation and peel it apart a little bit? This issue of a licensed mental health facility isn't something I don't think that our committee has encountered. Is that related to Maine Care reimbursement eligibility?
It is related for Maine Care reimbursement. As Dr. Zager was mentioning, he could probably speak to this more specifically, having a private practice, but they do have to have different, to get the equivalent reimbursement rates, they have to then become a licensed behavioral health organization or a licensed behavioral health provider in a different way. We are still treating physical care and mental health care as very different entities, where really they are all part of the same body in our whole healthcare system. And this is one example of where that creates a burden on medical practitioners to integrate within their practices. So they do not have the funding to afford to pay those at a rate that they would need to have a social worker or a counselor or something like that within their practice. And so they, as he mentioned, they do not have a lot of excess capacity for supporting that funding. So they end up reducing the access to that within the practice.
Okay, Representative Matheson.
Thank you, Madam Chair. Thank you, Ms. Shaughnessy, for being here and for all your hard work here. I just wanted to back up to number 1 real quickly. I guess I'm curious about this recommendation, considering that there hasn't been a rate increase for 2 decades. So I don't know if I totally understand this recommendation.
I'd be happy to explain it a little bit more and kind of tease it out a little bit. So yes, you are very correct. There have not been rate increases within behavioral health care for in some of the services over a decade, since minimum wage was around $6 an hour. So obviously over time, it has had a negative effect on the capacity of providers to continue providing these services. What the department did under this administration was began this huge kind of meta Maine Care rate analysis project. And one of the bills that's going to be before, I believe it's through in front of HHS, but it's codifying their new approach to a continual rate review process. So they are trying to work their way through all the different Maine Care rates and do rate analysis and provide new rates that actually do cover the cost of providing the care. So they're in the process of that. And obviously they can't do all of them at once. So they've been doing, different ones at different times. They are slated to deal with some more of the behavioral health rates over this year. the problem we're having is that the convergence of the pandemic and the increased need is hitting a system that is already so severely stressed that if they don't do this very quick, we're going to continue to lose providers of care. We have seen, residential and outpatient care closing down across the state, and on a every couple of months we're seeing another one close down because it's at such a critical point. So this is a key piece that really has to be addressed.
Representative Tepler.
Thank you, Madam Chair, and thank you for being here, Ms. Shaughnessy. I wanted to know who issues licenses for behavioral health facilities. I guess I'm confused between the licenses that practitioners are issued and the licenses that go to a facility. And if a licensed practitioner works in an unlicensed facility, what happens?
So, Senator probably could probably speak to that a little bit more specifically to how it plays out in a medical practice, but they do not get the same reimbursement rate unless they apply for this other licensure. And I believe it's just through DHHS's licensure and certification department, but it's a specific kind of licensure, and which I'm going to get to sort of in the next one that I'm going to discuss of our recommendations. What it does too is adds an additional administrative burden of work that has to be done, paperwork that has to be filed. There's a greater administrative burden on behavioral health than there's on medical care. Even though they are both services that are part of the healthcare continuum, they're both done by credentialed, clinicians and providers that are working within the scope of their practice, that have other, markers they have to meet to show continued quality of care. But there's just a different level of burden if they have to get that license to get that equivalent rate.
So I guess
so they don't do it.
Okay, I understand that. I'm confused though. If I'm a practitioner and I have a license to practice behavioral health care, and I have my office inside a medical practice that is doing physical health care, and I can see patients within that practice, I am being reimbursed at a different rate than if I open up my own little office and people come to see me there?
Yes, and depending on how the payment structure is, if you are working, kind of under that or just renting space within it, it can have different impacts. But yes, there are different rates that would be paid. One of the things too is one of the things I'm going to get to a little bit later is to mention is issues of carve-outs with behavioral health. So you can have a medical practice that has within its offices a psychiatrist, not a psychiatrist, but a therapist, a social worker providing counseling, who you are referred to by the medical practitioner. You go to see them, and then you find out afterwards that they're not actually in network, even though they're in the same facility and under the same auspices of the medical provider that you were just seeing, who referred you to them. So it can get very confusing, and that's a piece of that carve out. And again, what these three other recommendations, is 2, 3, and 4, are combined, trying to get at the fact that we treat behavioral health differently than medical health, and have different barriers and structures and systems and carve outs that confuses the system, costs more, and reduces access.
Representative Arford. You're on mute.
Sorry about that. Thank you so much, Madam Chair. And thank you, Ms. Shaughnessy, for being with us today. This is an extremely important report out, and I do appreciate it. I just want to make sure I'm on the right page with you. For the first, at least number 2 and 3, are we talking about main care as a set main care alone, or are we talking about main care and private insurance?
So
know-
under, oh, sorry, go ahead.
Yeah, I know number 4, speaks directly to commercial insurance, but what about these other 2?
2 and 3 definitely apply to main care. And I believe, and again, I don't do as much work with third-party carriers, but and Representative Zagar could probably speak to this, but I do believe that even with number 2, with private carriers, there's a whole different setup that they have to do to have that integrated behavioral health within their practice. I don't know if he wants to say anything about that.
Representative Zager, did you want to speak to that, Ms. Shaughnessy's reference?
I thank you, Madam Chair. I would just kind of add, like illustration, like we indeed had to contract with an entity, like there's entities like Sweetser and Spurwink that have that basically are the practice, but that's not the location necessarily where they're being seen. So they were seen at our practice. These are patients who have various conditions, situations, and one or more of them responsive to counseling. We had contracted out, but the barriers for that, for scheduling, for the EMR, electronic medical records that are not integrated, for the billing surprises that patients would get. I mean, it's not very patient-centered to kind of have this confusing setup, and we need obviously less confusion in our healthcare system, not more. And so that's kind of how we dealt with it. As far as the exact specifics, we could certainly get somebody for the formal work session to answer the committee's questions on that.
Okay.
Yeah, thank you. So yes, it does apply to both. That number 2 is sort of main care, but also levels of complexity that come with private carriers. 3 is definitely main care, and 4 is definitely private carriers.
Yeah.
But again, we really urge that 2, 3, and 4 all need to be done, or you start popping the bubble, or squeezing in different places, and it's going to become inequitable in some other place.
Thanks. Ms. Shaughnessy, Representative Brooks, before I call on you, I'm hoping Ms. Shaughnessy could just get through her last recommendation as well that has to do with commercial payers specifically, I think, which is more in our wheelhouse here. And I think it's going to echo some of the things that we've already spoken about this year. So if you're willing to hold your question, and then we can wrap up that 4th bullet.
Okay. So the one I was just sort of on was this, the number 3, which is the main care carve out that we have, with contracting KEPRO to be the administrative, gatekeeper for behavioral health, puts it at a different setting than other medical care that we have through main care. And it adds that extra layer, and it eats up staff time. It eats up time, it eats up time within the rate that's being paid to do the service. And what happens sometimes too is that it actually impacts getting services into rural areas, because they're spending so much of the rate on these administrative pieces. They can't cover the mileage that's not reimbursed to get providers out into rural areas. So 3 really has a huge impact as well on access. Number 4 is this, again, this carve out piece that we see with the private carriers. You can, and I talk a little bit more on my second page. Is it my second page? Yeah, on my 3rd page. Sorry, on the 3rd page of my presentation that I have today, I really talk a little bit about how this impacts. But basically, in the U.S., we have treated private and public payers have treated physical and behavioral health differently. Behavioral health services face different billing, credentialing situations, carve-outs that insurance policies put in place, as in some places almost like a rationing. It plays out as almost like a rationing of care within behavioral health. It's confusing, as Dr. Zager mentioned. We policyholders get confused, providers get confused. It delays reimbursement and provides inconsistent reimbursement. In 2008, the Mental Health Parity and Addiction Equity Act required that health plans provide mental and physical health equally. However, we are seeing across the country still, and we hear of this in Maine, insurers are often not covering it the way they should. there are inadequate provider networks, and there are unreasonable criteria to qualify for coverage, are the two critical pieces that play out in these carve-outs. And as Dr. Zager was saying, most insurers have like a separate entity too that will be providing the behavioral health, and the network, the adequacy of that network is shown out in studies across the states, that it's always far more inadequate than the medical side of the provider network. The piece that I was talking about, where you can be referred within a medical practice to the therapist within the medical practice, having an office in that building, but they're contracted through a different entity, and you go see them several times thinking you're going to pay, which you should be able to pay just your $15 or $20 copay for a medical visit, because it's a primary behavioral health visit. And then you get a bill for $60, $70 because, oh, they're not in your network, even though they're in that building, they were referred within that practice. And if you have private insurance, all of a sudden you have this surprise billing. We hear about this with, operations in hospitals, sometimes with the anesthesiologist, but it's happening within behavioral health care as well, as we try to integrate within the private practices. So I do have on page 3 some, sort of examples of what happens with inadequate provider networks, and with these different kind of criteria, some reports, links to reports that have been done, and some lawsuits that have actually recently challenged this, but have not fully eliminated it. So to eliminate that would be a key piece if we're looking at trying to provide access and reduce costs and get people the care they need at the basic level. And I would just refer you to really quickly in the full report, Dr. Zager mentioned the breakout of sort of the pyramid of care to give you an example of care within behavioral health levels of care. On pages, I think it's 108 and 109 of the report, I added these charts that were put together by the Office of Behavioral Health and Office of Child and Family Services, and they show the pyramid that on the lower level, they're the less expensive, more impactful primary care levels of behavioral health, all the way up through the more intensive, and more expensive levels of care. And if we don't get more money going into those lower levels of the behavioral health pyramid, in community and integrated care, we are spending it on those upper levels. So if you want to take a look at 108 and 109 of our full report, that references that. And I'd be happy to answer any questions about the inadequate provider networks and the criteria that is unreasonable in qualifying for coverage that gets set for behavioral health versus medical health. But I did outline some and gave some reports in that third page of my report for today.
Representative Tepler.
Thank you, Madam Chair. Did Representative Brooks still want to go ahead, and then I'll ask my question?
Representative
Sure,
Brooks.
thank you. Thank you, Chair Tepler and Chair Sanborn. This is just really a great work. It has proven beyond, in my mind, any doubt that our ancestors, whether it's my great-grandmother or your great-grandfather, etc., have known for a long time, in my mind, that talking to people, communication helps. So to put it simply, it proves that a more simple formula, like providing food, a safe, healthy place to call home, adequate education, transportation, all the things that we would like to have in a community, that the resources are there. And if we kept it more simple, like in medicine, we learn to do what we call it history and physical. So we take somebody's history and do a physical thorough exam and proceed from there. And that really ties together families, friends, fears. And I think with the pandemic, sometimes it does, unfortunately, to find a way out of pain, suffering, sometimes the unthinkable, that something like this
Brooks, do you have a
helps.
question?
So my question is, with resources and funding, one problem I've seen with healthcare right now is it seems like we have a system of denial on many levels, whether it's denial of a couple shots in the knee to keep enabling somebody to walk, a rollator to also help with that stamina. So what do you see the potential is for this going forward?
I'm not exactly sure how to answer that. I mean, I think it is clear from so many different studies and reports that providing that, as you mentioned, sort of the basic needs. We talk about social determinants of health, providing access to those, providing supports both for physical and mental health to keep people sustained in their community is far more productive for our communities and for people within the communities, and it's far less costly. We do too often put barriers there, and then we have to pay for them where people end up. And with mental health, sometimes people end up in our jails. We're paying a lot of money for people sitting in our jails, actually being harmed rather than helped for their behavioral health needs, because we did not put the money into some basic community level care that could have helped sustain them in their community and reduced their likelihood of escalating into a situation that gets them involved with law enforcement. So yeah, we need to turn these pyramids on their heads and spend more money down on the lower levels.
Representative Tepler, go ahead.
Thank you, Madam Chair. My question, Ms. Shaughnessy, thank you for being here. I want to go back to the concept of an adequate network in behavioral health. This committee does not have a whole lot of oversight of rates and licensure that's happening within DHHS. So I am most interested here in how we can advise the Bureau of Insurance on judging network adequacy in behavioral health. So if you could fill in some of the gaps there, that would be very helpful.
Getting at exactly what's happening within private third-party carriers and where and when these carve out or barriers are getting put in place or are being created, whether inadvertently or intentionally, is very hard. It requires a lot of reporting by those carriers that the Bureau of Insurance can then analyze and oversee and be able to tell. The Kennedy Forum, which is a national group started by one of the Kennedys, I believe it's Patrick Kennedy, but they have been working on model legislation that states can adopt to try to verify whether or not there is parity. So they're model parity laws that a lot of which are entailed of reporting to bureaus of insurance from third-party carriers to be able to judge whether or not we are seeing that inequity in access between behavioral health and medical health. I could, refer you to the links to those. With network adequacy, what ends up happening is, there are, there's several studies, and I've got links in my report that I had for my remarks today, but they have found that a behavioral health office visit is over 5 times more likely to be out of network than a primary care appointment. And sometimes without the consumer having any idea that it's going to be out of network. They also find more difficulty getting in finding an actual in-network provider and a facility for mental health compared to general or special medical care. We are creating 2 different systems in that a network should be a network of care that a provider has, that a carrier has. They should have a network of care, but they have like these different carve-outs for behavioral health and then a different network for the medical health. It's very hard to get to exactly how it's being done or indicators that it is happening. If you look at the lawsuit, the Witt versus United Behavioral Health Insurance Agency, it was a huge lawsuit, and it brought many patients and consumers together. It took a long time to dive into and analyze the data, and the court did find that that United Behavioral Health was straying from generally accepted standards. But again, it took a while to get there. But the model legislation would put in place indicators of data to be provided to the Bureau of Insurance that they could then analyze in a way that they can't right now. We do hear anecdotally in Maine that people are experiencing these things.
Ms. Shaughnessy, we have certainly heard about this in our committee, and I've heard about it personally from some constituents and providers that I work with. I'm wondering whether one solution might be to mandate network consistency by address. And so I'm wondering if like practice level credentialing could be, or networking could be mandated. And I was wondering if you were at all familiar with anybody who had tried that, or any other states that had done credentialing for private insurance at the practice group level as opposed to at the individual provider level.
I don't, I'm sorry, that's not my particular wheelhouse to really dive down into. I know that the Kennedy Forum is very invested in seeing this happen in every state, and they would send somebody here to talk to you in a work session, next week or the week after probably, because they are so interested in helping educate state legislators about this issue so that they can provide better oversight.
Okay, that would be really helpful, because I think this, Colleen, just as a note for our work session, I think this, our next work session, I guess, I think this really relates very much to the other issues around access and credentialing that the committee has talked with Anthem about and has talked with the Bureau about in terms of their mental health parity audits over the last couple of weeks. So it's something very much on my radar, and this seems like a vehicle that we might be able to actually put some legislative parameters in place to make this better.
I would share a quick caveat, if I could, that I really stress that 2, 3, and 4 need to be happening together. And I know 3 and some of 2 is really not in your purview, but to maybe even have a joint meeting with HHS regarding it, because if you do something that helps get more integration in a medical office for folks, there's still going to be a need to refer for more intensive and more home-based supports that people need. And already many doctors are hesitant to even review somebody's mental health state because they don't know where to refer anybody to. There's not the community-based services to even refer somebody to. So sometimes they don't even want to do the assessments to see. If we don't do the main care side of it, we're going to run into problems still, because even if you have private insurance, and there are, I think Representative Tepler has a bill regarding this, but even if you have private insurance, there are some services like for children, mental health, that they're just not offered by private carriers. So you have to get a Katie Beckett waiver, which allows you, even though you don't qualify financially for main care, it allows you to qualify for main care so that your child can get those services that are only done by main care agencies and providers. So there is a connection even between the private carrier and the main care situation that would sort of behoove you to maybe have a joint meeting with HHS to discuss. Because like, again, if you expand access in one place, you're going to have more impact someplace else. They'll have more therapists in their medical office maybe, but they won't have anybody to refer to for that more intensive care. So we're still going to have, an inequity in the system. That's just my last 2 cents.
Yep, understood. I had a question from about where the report that you're referencing that has over 100 pages is. I'm not sure if maybe Colleen can direct us to where that is. Is it the stakeholder appendices piece?
Yeah, it's the stakeholder report, the full report in the appendices. The appendices go on to 179 pages in all.
I think it's
108.
Yeah, 164, I think, is where it started. I forwarded, Representative Connor asked me and I forwarded it to him, but I can forward it all to everybody as well, but it's in one of the appendices. And if you pull up the PDF version of the report that's online, I think it's page 164 where their report starts.
And yeah, and on 108 and 109 are the pyramids that I talked about of behavioral health, where you know, the different levels of sort of the primary behavioral health and ratchets up to more intensive care.
All right.
Do you find it?
I will forward it again by email to the committee. So I'll send it to the whole committee again.
Okay.
Make it easy for you, hopefully.
Okay, thanks.
Yep.
Yeah, I definitely read through the recommendations, but not all the way to 104.
Oh, it looks like Dan already put it in the chat.
Got it. Okay.
He's quick.
All right, and that's where the reference to the case law that you described is as well.
Actually, the reference to the case law is in my presentation today. I wanted to give you a little bit more background on those pieces of sort of the carve out side of things, the inadequate provider networks and unreasonable criteria for coverage that we have seen. And that's where the WIT v. United Behavioral Health law case is. And then also a 2019 report and a 2016 report that highlight the carve out inequities. That's in the paperwork that I shared for my presentation today, which you should have.
Okay. I don't think the outline of Ms. Shaughnessy's remarks that Colleen sent to us has those pages. It's just 4 pages and it's just a PowerPoint that doesn't have any reference.
I sent over last night, I believe, my remarks for today, which is I think 3 pages, and on the 3rd page is some links. Did you get that?
Colleen, do you know where we're navigating at this point?
Hold on.
It should be in an email from me, I believe, to Colleen and
yeah, that
a few
was
others.
The attachment that you sent this like early this morning, Mallory, was the presentation. It was the presentation. So maybe you just sent the wrong attachment.
Oh, well, yeah, that's a that's a problem.
If you could send it again, that'd be great.
Okay,
So,
let me do that.
Thank
Sorry
you.
about that.
That's
So
okay.
I think it might make sense for us, sorry, Colleen, we'll assemble the pieces that we've just referenced into a single email after the hearing today or the briefing today, so that we kind of have all of those links or all those attachments in a single email for us, so we can navigate and read through that material. And I apologize, we're sort of wanting to drill down in just very specific places when we had a voluminous record before us, but we wanted to really zero in on this piece that Ms. Shaughnessy brought to the table, because I think there's a lot of opportunity there for our community to take some good action. So
if you would like, I could reach out to Kennedy Forum if I had a date to share with them, or find out what date they could join you.
Yeah, I think that will have you work with Colleen to put that together for us. I do think that would be really helpful if they're working on this credentialing issue that we have, and just mental health parity in general issue that we have definitely been circling around and dancing around, I think, for a while in this committee. So this may provide us another resource to be able to really zero in on something we can do with regard to it. Okay, are there additional questions from the committee other than needing to know where all of our resources are in our emails? All right, I don't see any extra hands go up. So thank you so much, Ms. Shaughnessy, for that briefing, and Representative Zager for bringing together the concepts in this bill to get us to the stakeholder process, to get us to this potential next step with regard to behavioral health, at least. Are there any additional comments from our guests from the stakeholder group that are already in the panel? Representative Zager, go ahead.
Thank you, Madam Chair. I just want to acknowledge and thank the committee and the other participants. This is hard work hard policy work. We all can see that, but it really can help Mainers. And so I salute everyone here. Thank you.
Thank you, Representative Zager. And next, I'll just open it up to anyone in the attendee space who was part of the stakeholder conversations that may want to make an additional comment on any of the presentation that we have heard so far this morning. You can raise your electronic hands. All right, I'm not seeing anyone in the attendee space raise their electronic hand, but I did see Representative Tepler raise her hand. So go ahead, Representative Tepler.
Thank you, Madam Chair. I'm wondering if Ms. Harrington has any brief thoughts to share with us about what kinds of data they are not currently able or collecting that will be useful in analyzing some of the information that Representative Zager and the committee have shared with us.
Okay, I can bring Ms. Harrington in. Hopefully she is not going to be too caught off guard by that if she's at her desk. She's here for a later work session, so we can bring her in and see if she's with us. Good morning, Ms. Harrington. Are you with us?
Good morning, I am. Unfortunately, my video and audio are not working together, so I'll just leave the video off.
Okay.
I did hear Representative Tepler's question, and I'm a little bit unprepared to respond comprehensively, but let me say this. I think we have a solid set of data, but there are some limitations around what we collect for substance abuse disorder as a result of some federal laws. So there are some gaps there, but that's based on federal laws. We do get that data, or we have access to that data from Medicare as well as MaineCare. So, we can get some sense from those populations. And I know that there are some differences, but so I think in the end, we've got a solid set of data to provide some context directionally. And the state of Massachusetts has done a lot of work, and they've developed a pretty detailed specifications manual on the data that they used and how they put this together. And in many cases, they asked the payers to self-report some of the information, and that may be something we want to take a look at after, if this is something that you pass, that may be something we want to take a look at in the second year, based on any, significant gaps that we see in our data. But I don't think that that's necessarily needed in this first round. Just my thought.
Do you mean self-report on the substance use treatments that would otherwise not be reported
Yes.
due to federal law? Okay.
Yep, and I don't know specifically what Massachusetts does around that. It probably is more like an aggregated, so it's not by claim, but it's more give me your totals. And I think for these purposes, that's all we would be looking for.
Sure.
But I know just trying to get non-claims based payments from the payers when it's not a regulation is challenging because they have other priorities, which are those that are regulations. So I don't want to leave the committee thinking we could get it easily. I think if it's something that we think after the first year we should come back and talk to you all about.
Okay, and that's just a subset of the behavioral
Yes.
spending.
Yep.
Okay.
Yep.
Yeah, I'll be all right. Ms. Shaughnessy, go ahead.
Thank you. I just wanted to share with you, I dropped a link in the chat to a report kind of fresh off the presses from Department of Labor, Department of Health and Human Services, and Department of the Treasury federally in a deep dive that they did on parity recently. It's got very updated information on what they found across the country and on compliance analysis. So it would be good for the committee to take a look at that as well. It really highlights how some of these things are done and the data needed to capture that.
Thank you so much for finding that report. I heard about it on NPR this morning and then was trying to find it during this meeting and wasn't able to. So thank you for dropping that link.
Sure.
And I do think that's going to be really helpful backgrounds for the committee as we continue these conversations. Thank you. All right. Anybody else? Representative Arford, go ahead.
Very quickly, I want to make sure I understand what was just said about the non-claims-based treatments. Are you saying that for the practitioners, I know there's a number of single or small group practitioners who operate out with behavioral health, at least, that operate outside of insurance. Are you saying there would be a way to capture the claim? Well, they aren't claims, actually, the payments that clients make to them?
So no, Representative Alford, I was talking about non-claims-based payments are payments that health insurance plans, main care, Medicare make to providers that are in the form of like an incentive payment for good outcomes or payments to help them expand health homes, things like that, that would they're payments that are made to support a structure or care or services, but they're made outside of the traditional way you pay a claim, if that makes any sense.
Yeah, thank you. Great clarification.
That was a good question. All right. All right, seeing no further hands up, I think I will wrap up this conversation and really thank everyone who was involved in helping us push LD 1196 towards some sort of helpful vehicle for this committee to improve our health system. So thanks very much for joining us, folks. I think we'll take a 5-minute break, and then my intention is to convene a work session on the last two bills that are on our list today, LD 1837 and 1842, which had no controversy during the hearing. So we will convene a quick work session on those starting at 11:10. And then we'll break for lunch and caucuses and pick up the other 3 bills that we have scheduled for work session today. So again, thank you, Mr. Moran, Ms. Shaughnessy, and do we still have Mr. McLean and Ms. Harrington? Thank you guys so much for joining us today, and we really appreciate your assistance to the committee, and we'll see the rest of the panelists back at 11:10. Thank you. Okay. Welcome back, everyone. As I mentioned before the break, let me wait for a few more faces to appear. If you're sitting at your desk, if you could turn your camera on.
I'm here even though you can't see me.
Yes, thank you for being there, Representative Quint. Unfortunately, you won't be able to register a vote by phone, but you'll be able to register your vote through your presiding officer after we wrap up. All right, I'm gonna just go ahead and get started. There we go. There's more faces. All right, welcome back. So we're gonna start by opening a work session on LD 1837, an act to clarify the appeals process for decisions related to the Maine health insurance marketplace. And Colleen, you can present your bill analysis for us.
Sure. This is LD 1837. As Senator Sanborn said, this relates to the appeals process within for decisions made by the health insurance marketplace. This was a bill that was submitted by the Department of Health and Human Services. The bill specifies that an appeal of a decision that's made by the health insurance marketplace to the Department of Health and Human Services Administrative Hearings Unit, which is their appeals entity, would not be subject to judicial review under the Maine Administrative Procedures Act and the Maine Rules of Civil Procedure. Instead, what the bill does is it provides that such a decision may instead be appealed to the United States Department of Health and Human Services pursuant to their federal regulations. There are regulations under at the federal level that for state-based marketplaces, there be an availability of an appeal directly to the Federal Department of Health and Human Services. And what LD 1837 seeks to do is clarify and resolve any potential conflicts between what's available under our state law with regard to the Maine Administrative Procedures Act and the federal regulations. So the bill is, as I mentioned, is just really intending to try to resolve any conflict, preserve the ability for someone to have an appeal of a decision made at the state level, but it would go to the Federal Department of Health and Human Services in these instances, rather than appealing to a court. One of the things that I think, as I was looking at the bill and wanted to raise for your consideration is, as the bill's drafted, it would take effect 90 days following adjournment of the second regular session. And wanted to suggest that the committee may consider clarifying the language with regard to any decisions of the marketplace that may be subject to appeal that might be made before the effective date of the bill. So you may want to consider whether or not there is an interest in adding an emergency preamble and emergency clause so that the bill would become effective once signed by the governor. As you know, emergency legislation does require a 2/3 vote of both the House and the Senate. But it may make sense to consider both adding an emergency, but also clarifying that the bill applies to decisions made by the marketplace on or after a certain date. So you capture sort of any potential decisions that might be made between or may have been made by the marketplace that are pending appeal, or might address the potential gap if you let the bill go forward as it's drafted. I did reach out to the Department of Health and Human Services and asked for their input. And I think that if the committee is supportive, they would be amenable to adding an emergency preamble and addressing the bill in this way, particularly if there's unanimous support among the committee. And Ms. Garrett Reed, I think, is here. And if you had any questions for her on that point, she could respond. And then lastly, we did get the fiscal information from the Office of Fiscal and Program Review that if the bill moves forward, it would have no fiscal impact.
Great.
I'll stop there.
Okay, fantastic. so let's see, Representative Tepler, go ahead.
Thank you, Madam Chair. And I wanted to ask Ms. Garrett Reed, who, although she's not in our panel, but is probably listening, whether there are in fact a number of pending appeals and whether we do need therefore to put an emergency on this.
Okay, I'm bringing her over. She'll be here in a minute, and then I'll ask you to re-ask your question. All right. Ms. Garrett Reed, welcome to the panel. And I moved you while Representative Tepler was asking the question, so I'll have her repeat.
Thank you for being here, Ms. Garrett Reed. I wanted to know whether or not there are in fact a number of pending appeals so that it would make a difference whether or not we move this forward as an emergency.
Thank you. Happy to address that question. To date, I think we've received 19 appeal requests to the Office of the Health Insurance Marketplace, and we have not had any of those appeal requests proceed to the level of a hearing by the Division of Administrative Hearings. All those have been resolved to date with informal resolution. So we may have one or two remaining open that have just sort of come in more recently and not been resolved. But in general, we've been able to resolve those without even reaching the level of the formal appeals resolution process within the department.
Representative Arford.
Yeah, thank you so much for being here, for coming over to speak with us quickly. If this bill passes, how will the people that are currently going through the appeals process, how will that process change for them?
So of those couple of open appeals, and some of this I suppose would depend on the effective date of the bill. Currently, they would have their appeal, if it were not resolved by the marketplace through informal resolution, heard by the Division of Administrative Hearings. This bill would only impact if they received a determination from that Division of Administrative Hearings that they disagreed with and wanted to further appeal up the chain. Before this bill comes into effect, they would have the option of either going to the judicial route here in the state of Maine, or appealing up to the Department of Health and Human Services, the U.S. Department of Health and Human Services, for that federal appeals entity to hear their case. After this bill comes into effect, we would just clarify that sort of the correct route for further appeal of our state level decision would be to the U.S. Department of Health and Human Services, and it would just remove that sort of required in statute level of judicial review that otherwise usually applies to what are known as final agency actions here in the state of Maine.
Thank you.
Representative Evans.
Thank you, Madam Chair. Ms. Garrett Reed, is there a certain timeline that the department has for clearing appeals at its level?
Yes, generally 90 days. There's some language around administrative feasibility of that, but yes, our timeline is typically 90 days, and that I believe applies at the federal level as well. So then there would be a further 90-day expectation for resolution of an escalated appeal to them.
Okay. Wondering if we have any further questions for Ms. Garrett Reed. All right. Seeing none, I'm going to send you back. Thank you. And I'm going to ask what is the committee's preference with regard to an emergency approach with some retroactive language. It sounds like it's unlikely to come into play, but if we've got unanimity, it's probably the cleanest and most appropriate way to go so that no one winds up in the courts on this issue. That should probably go to the federal HHS instead. Representative Tepler, go ahead.
Thank you, Madam Chair. I'm willing to make a motion that includes the emergency preamble. If there's disagreement around that, I will withdraw the motion.
Okay. Well, why don't we have you make that motion, or we'll consider you having made that motion, and I'll look for a second. Is there a second? Seconded by Representative Brooks. And is there further discussion on the motion? I don't see any further discussion. So I'm going to assume that we've got assent to the bill. Colleen, go ahead.
I just had a question. Would, in addition to the, just for clarity, in addition to the emergency preamble, you would also clarify that it applies to any marketplace decisions pending on or after the effective date of the legislation, something like that. Okay, thank you.
Yep, exactly. Just some retroactive savings language there.
Yep.
Great. Okay, so the motion is ought to pass as amended, and I will have the clerk call the roll.
Thank you. Okay, Senator Sanborn,
Yes.
Senator Brenner,
Yes.
Representative Tepler,
Yes.
Senator Stewart. Senator Stewart absent. Representative Afor,
Yes.
Representative Bleier,
Yes.
Representative Brooks,
Yes.
Representative Connor,
Yes.
Representative Evans,
Yes.
Representative Matheson,
Yes.
Representative Malavano,
Yes.
Representative Morris.
Yes.
11 members having voted in the affirmative. 1 absent.
Great, thanks. All right, so we will next move on to LD 1842, which is a review of a major substantive rule from the MHDO, and I'll have Colleen present her analysis.
Okay, so I'll quickly go through LD 1842. As Senator Sanborn said, this is a resolve that provides for legislative review of portions of Rule Chapter 120, which is the rule that governs the release of data to the public that the MHDO is authorized to collect. The purpose of the rule generally will specify the permissible uses of the data, the data elements that may be released, the process by which data requests will be reviewed, and if approved, the process by which the data will be released, requirements related to public notice of data requests, the data use agreement that MHDO signs with entities before it releases data to the public, in both MHDO's internal use of the data and the security and the protection of the data generally. The changes to the rule that are proposed for your review do a number of things. They update the definitions in addition to adding several data elements available for release to authorized data recipients. And those primary updates relate to adding vital statistics and cancer registry data, as well as data related to race and ethnicity. The rule changes are based on how data users' needs have changed, as well as laws that allow for the collection and release of certain data elements. MHDO has indicated that the changes and the updates to the rule will align their collection rules, data collection rules, and requirements with the rules and requirements for the release of data. They will also allow data users to utilize data for their purposes, including, as I mentioned, increased data related to healthcare disparities and inequities, and data related to linking the MHDO data with vital statistics and cancer registry data. This is a rule that has been reviewed most recently by the legislature in 2016. At that time, MHDO presented a sort of a repeal and replace of the rule. And that was authorized, final adoption of the rule was authorized by the legislature then with one explicit clarification that any data that's released did not individually identify patients that received mental health services. You really didn't receive any testimony at the public hearing on this bill, except for the information that the MHDO provided, but there was some written testimony that was submitted following the hearing that I just wanted to highlight. Both pieces of testimony were in support of the changes to the rule, particularly with regard to linking the MHDO data with the vital statistics and cancer registry data, and also the ability to improve tracking and reporting of data regarding racial and ethnic disparities. We don't have the full fiscal impact statement yet, but in the past with rules resolved related to legislative review, any costs can be absorbed within the existing budget of the agency. So I expect that that would be a similar result here. And I'll stop sharing, and I'm happy to answer any questions. And as you know, I think Ms. Harrington is here and can answer any specific questions that you might have. Could also pull up, you received a copy of sort of the rule, sort of where you can see track changes. Happy to go through that if you want that level of specificity as well.
Thanks, Colleen. Are there questions for Colleen with regard to this rule review? All right, I don't see any. Is there a motion?
I'm happy to, oh.
Representative Matheson can go ahead.
I'd like to put forward a motion ought to pass.
Great.
For LD 1842.
Is there a second? Seconded by Representative Arford. And is there any committee discussion on the motion? Representative Brooks.
So I do see that with this issue, it's really important. I know historically, and maybe not that distant history, that we are very concerned about privacy issues with medicine and medical privacy issues. So that's one issue that comes to mind, and we want to make sure this is very not revealing a patient's medical information, but I think it's really a great system to help track disparities.
Okay, thank you. Are there any further comments or discussion from the committee? All right, seeing none, I'll have the clerk call the roll on this ought to pass motion.
Thank you. Senator Sanborn.
Yes.
Senator Sanborn, yes. Senator Brenner.
Yes.
Senator Brenner, yes. Senator Stewart. Senator Stewart, absent. Representative Tepler.
Yes.
Representative Alford.
Yes.
Representative Bleier.
Yes.
Representative Bleier, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Malano.
Yes.
Representative Malano, yes. Representative Morris.
Yes.
Representative Morris, yes. 11 members of the committee having voted in the affirmative, 0 in the negative.
Thank you very much. All right, so at this time, we are going to break and have lunch and caucuses. Would anyone be opposed to us coming back at 12:30 instead of 1 so that we could potentially have a shorter afternoon? How does that feel to everybody? Representative Evans, go ahead.
I have a meeting at 1. No, at 12.
You have a meeting
And
at 12.
I have a meeting at 12 with a hard stop at 1. So that would be my only input.
Okay, it sounds like you would miss part of caucus in any. So I'm wondering if we might just proceed This way you could do half of caucus at least and probably be back for much of our conversation, hopefully. So let's proceed with that plan if that's all right for everybody else. And we'll be back at 12:30 to do the 3 work sessions this afternoon. Thanks, everybody.
Mm.
Hi, Jess.
All right, so if you are sitting at your desk, if you could turn on your camera and let us know you're with us, that would be great. Perfect. Okay, so we are back this afternoon with several work sessions, and we are going to just take them in the order they were noticed. So we'll start with LD 1776, an act to allow pharmacists to dispense an emergency supply of chronic maintenance drugs. And I'll have Colleen go through her bill analysis with us.
Okay. So this is LD 1776. As it's drafted, the bill allows pharmacists to sell and dispense an emergency supply of a chronic maintenance drug to a patient without a prescription if the pharmacist is unable to obtain authorization to refill that prescription. The pharmacist has a record of the prescription in the name of the patient, including the amount of the drug dispensed in the most recent prescription or the standard unit of dispensing the drug. The language of the bill does specify that a pharmacist would not be allowed to sell or dispense controlled substances, including opioids, under these circumstances. There is a second provision of the bill that would require insurance companies to provide coverage in individual health insurance policies for the emergency supply in the same manner as provided for coverage of other drugs under the policy. You did get some testimony at the public hearing, but you also received a number of pieces of written testimony since the public hearing that is now uploaded in the electronic LD file that I wanted to note for you. And then I sort of split this up into, for purposes of the analysis, into questions that relate to the Title 32 provisions of the bill, which go to the authority of pharmacists to sell and dispense the chronic maintenance drug under these circumstances, and then a second piece of the analysis that relates to the insurance coverage provisions. So with regard to the authority for pharmacists under the licensing provisions in Title 32, as I think as was testified to at the public hearing, currently there is no authorization under the law for a pharmacist to dispense a drug without a valid prescription. Although in the testimony that you received, both from the Board of Pharmacy and others, it indicated that pharmacists do loan patients a small supply of a prescription drug, but that loan is not authorized by statute. So it was suggested to the committee that it would be appropriate to clarify in statute the circumstance under which a pharmacist may dispense chronic maintenance drugs in this situation when a prescription has expired and the pharmacist and the patient is unable to get authorization to refill that prescription. A number of questions were raised about the language as the bill is drafted, whether or not chronic maintenance drugs needed to be defined further. The bill defines it as a medication prescribed to treat a chronic long-term condition that is taken on a regular recurring basis. So suggested that the committee might consider thinking about whether or not those terms need to be defined further, or whether the determination about whether to sell and dispense a drug under these circumstances, which drugs can be left up to the professional judgment of the pharmacist. It was also suggested that the committee might consider some additional parameters around what is meant by an emergency supply. A number of suggestions were raised related to whether or not the committee specify the amount that may be dispensed, or limit the authorization to once per drug over a certain amount of time, and whether or not the committee might consider specifying the scope of the authorization. The language would allow dispensing of an emergency supply for which a pharmacist has a record of a prescription. Number of suggestions came in related to requiring that the supply be not for more than 72 hours or for another short period of time, in terms of how much of the prescription was how much of the drug was provided in an emergency supply. Was also suggested that the committee think about clarifying to specify that the record on file must be for a prescription issued within a certain amount of time, within the last 120 days, for instance, or within X amount of days. The Maine Medical Association's testimony also raised the questions about the impact of the legislation on prescribers' authority and the clinical judgment of prescribers, and whether the bill needed to include some specific requirements for pharmacists to notify a prescriber if they've dispensed an emergency supply under these circumstances. It was also suggested in testimony from the Maine Medical Association that you consider amending the bill further to specify that the provisions would not allow dispensing of Schedule II or benzodiazepine drugs, and I probably am butchering the pronunciation of that, drugs related to the treatment of mental illness. And then lastly, the bill as drafted does provide authority or direction to the Board of Pharmacy to adopt rules related to the legislation. The language says the Board of Pharmacy shall adopt rules. The Board of Pharmacy's testimony suggested amending that language in the rulemaking provision to provide authority to the board rather than a directive, given their other rulemaking responsibilities. So it was suggested that you consider amending the bill to, instead of saying the board shall adopt rules, to the board may adopt rules. And I think the sponsor had indicated her willingness to go along with that suggestion. I did want to note that I believe the committee received some further suggestions for amendments by email this morning by the Maine Medical Association, I think in part relating to some of the suggestions or the questions that I raised earlier. I could pull that up for you if the committee is interested. And then I did provide some links to examples of other states that have addressed this situation in their state laws. So those were sort of the questions that I think related to the Title 32 provisions in terms of the authority of pharmacists. But then, as I mentioned, there's also a section of the bill that would apply to health insurance companies and require carriers to provide coverage for emergency supplies of chronic maintenance drugs in the same manner as coverage for other drugs under the policy. The bill as it's drafted applies specifically to individual health insurance policies. And I think the testimony that we received from the sponsor indicated an intent that it would apply to both individual and group insurers. So it would cover all types of policies that can be regulated under state law. So if you do move forward and you want to include a provision that in Title 24A that clarifies how insurance companies cover this, you would want to make a technical amendment just to make sure it applies both to individual in the individual and group context. There was also a question raised about whether or not the bill as drafted is proposed mandated benefit that would require review and evaluation pursuant to the statute, which I think the committee's familiar with, that process for review and evaluation by the Bureau of Insurance of proposed mandates. The Bureau of Insurance's testimony noted their belief that the bill would not be subject to review, but I did want to note that you did receive testimony from Anthem and other carriers raising that as a question, or that they indicated their disagreement with the Bureau's conclusion, and they suggested that the committee should have the bill or the proposal go through a review and evaluation pursuant to that statute. We've also got some questions about how insurance coverage may currently be provided for, bridge prescriptions, I think was a term that was used during the hearing, for when pharmacists may loan or front a small amount of a prescription to a patient before or without a refill or authorization for the refill. The insurance companies were asked to provide more information about how these prescriptions are currently being paid or covered. I think they provided some initial information, but wanted to confirm that for the committee. And then there was also suggestion that the committee might specify that the bill applies only to drugs covered under the policy, whether or not you think the bill would need to be clarified on that point, and also whether clarification is needed that carriers may apply existing cost sharing requirements under a policy for any prescriptions that might, any drugs that might be provided under this by a pharmacist under these circumstances. And then the last two things I would mention is the bill as drafted isn't drafted as an emergency. So if it goes forward without change, it would become effective once signed by the governor. But I did want to note that typically when the committee makes changes to the terms and conditions of health insurance policies, you often will include a specific application clause for those sections of the bill that require health insurers to make changes to their policies and contracts. And so you may want to consider whether or not the emergency is necessary, and or whether you need to add a specific application clause that the policy or the law, if it's enacted, would require health insurers to provide coverage for emergency supplies of chronic maintenance drugs under the requirements of the bill. And then a reminder that I think everybody's aware of, that when you do make changes to Title 24A related to health insurance, the state laws don't apply to self-insured plans. They wouldn't apply to coverage under federal programs like Maine Care, Medicare, or to coverage for federal employees. And I'll stop there. I'm happy to answer any questions or pull up any additional information, whether you want to look at current law or some of the other state laws that have addressed this issue.
Thank you, Colleen. Representative Tepler.
Thank you, Madam Chair, and thank you for that bill analysis, Colleen. I wanted to ask about the benzodiazepines because I'm curious what other states are doing with them. I recognize that some of them are potentially addictive drugs, or that they are potentially addictive drugs, but I also realize that they are used in patients with diagnosed seizure disorders, and maintenance of medication for a diagnosed seizure disorder is really, really important. So I guess my concern would be that we don't necessarily want to limit that, or if we can write some very specific language around benzodiazepine that says, except those used in patients with diagnosed seizure disorders, because I don't want those folks to have to go without their medications, which are serious chronic maintenance medications.
I'm not aware in any of the other state laws that I reviewed that there's specific mention like you just suggested related to sort of carving out that. And I'm not aware of any other state laws that specifically mention that category of drugs. There are other state laws that sort of carve out Schedule II controlled substances, as you know, LD 1776 proposes. But I think if you wanted to sort of include the exception to the exception that the Maine Medical Association suggested, and sort of prohibit using this authority to prescribe benzo drugs, if you wanted to add that exception for seizure disorders, I think you could clarify that and add that to the legislation.
Thank you.
My question, Colleen, is around the health insurance language. There was testimony or questions, which I'm not positive they're totally in good faith, about whether we needed more language around copays and cost sharing, and that it had to be covered before, because it has the words in the same manner as coverage for other drugs provided in the policy. maybe that needs to be in the same manner as coverage for this drug were it not in an emergency situation. And we can wordsmith that, but isn't that the sort of nugget here that we're trying to crack, is that we don't treat this differently just because it's dispensed in an emergency scenario?
Yeah, I think so. And I think that that really is, I mean, I don't want to speak for the sponsor necessarily, but I think that that's how I would interpret it, that they, insurance companies wouldn't do anything differently in terms of coverage of this particular drug. If it was covered under the policy in a regular circumstance, it would be covered in this circumstance. And my assumption was that any cost sharing that would apply would continue to apply. But if they needed, if for some comfort, additional comfort, I mean, you could certainly wordsmith that language a little bit further to make that clear. But that was my assumption as in reading the language.
Okay. Are there additional questions for Colleen? I can see Mr. Moran's hand, and I assume he'd like to weigh in on the benzos question, but I'm not going to call on him right now to do that. So we'll circle back to that piece at the end of our committee discussion, because I think it's a relatively discrete point. Committee discussion with regard to how you'd like to proceed. I'd be okay sort of putting together verbally an amendment as a motion, if that would be helpful to kind of get everybody on the same page, but I don't want to be preemptive in doing that if somebody has a burning desire to jump in here. All right, not seeing any burning desires. Let me attempt to just kind of walk through a proposed amendment verbally, and then we can talk about any of the pieces of that. So it would start by, let's see, I'll just start with the 24A sections, which is that it would include not just in the individual health insurance policy context, but also in the group policy contexts and the HMO, or that's a separate section as well. So in all three sections, they would have roughly this language, but probably wordsmithing that last clause so that it makes clear it's in the same manner as if the prescription were dispensed in the usual way, as opposed to as an emergency supply. And then I don't believe in this context, just to deal with the other insurance issue, I don't believe in this context that this is a situation where we would need to give us an effective date certain, because again, this is one of those emergency supply scenarios as opposed to a change in benefits or something that the insurer needs to be having a long lead time in order to be able to forward appropriately. And it may be that they're still just borrowing against the next prescription and putting it through that way because that's been the practice. I wouldn't think that pharmacists would necessarily change their practice from the bridge process that they have been using. So I think those are the insurance provisions. On the other provisions, I'm going to try and walk through kind of a voodoo amalgamation of a couple of different amendments that were proposed to us. So it would start with the language of the bill as proposed in section 2. But then we would add a provision for Mr. Moran's proposed amendment that would require the notification of the doctor who previously wrote the prescription. Mm-hmm. And we would also add a section there that says that the pharmacist will provide only 2 refills of any given prescription within a year. the quantity of the refill is in conformity with the prescribed directions for use. And that the drugs must be dispensed. No, sorry. In a quantity up to 30 days supply. And for drugs that must be dispensed in their original containers, the pharmacist may dispense the smallest size available outside of a 30-day supply. And then I would also add from Mr. Morin's text, in the pharmacist's professional judgment, the medication is essential to the maintenance of life or to the continuation of therapy in a chronic condition, and the interruption of therapy might reasonably produce undesirable health consequences or cause physical or mental discomfort. We liked that language as well. I think those were the pieces that I wanted to pull together into an amendment. I think I will review, take the emergency enactor off of the bill as well as in my proposed amendment.
Yep.
And then I
Rulemaking.
the rulemaking should go to a May.
Yeah. Okay.
And I think that's everything, but I'll look to the committee to see if there are any friendly suggestions for anything I might have forgotten. Representative Tepler.
The benzodiazepam amendment should probably go in because those are potentially dangerous medications, except in the case of seizure disorders.
Okay. Is that how we want to handle that? We'll add in benzos except in the case of seizure disorders.
Anybody want to let me know what they think about that? I am concerned because I do think that Xanax and some of those prescriptions can be used inappropriately.
I agree, and which is right. I agree as well. Yeah. Representative Morris, go ahead.
Well, thank you, Madam Chair. No, we would, I certainly would agree with what you have stated. I think most of our discussion was certainly around just any safety parameters and making sure people are still seeing their doctor in these situations. And I think you've addressed a lot of that with this amendment. So.
Okay. Representative Connor.
Thank you, Madam Chair. I guess this is an open question to anybody in the committee. You'll have to forgive my my lack of knowledge in this, but I don't get a whole lot of prescriptions at the pharmacy. So I just want to make sure that there's not already a statute in place that states that it has to be the pharmacist that is filling this. A technician can't do it. I know when we start putting emergency bills in place that, you know, rules kind of get loosey-goosey and can fly out the window. So the bill clearly states that a pharmacist can do it, but it doesn't state that a pharmacist technician cannot do it. So I just didn't know if that was something that we should put in there as another guardrail, or is there something already in Maine statute that says a pharmacy technician cannot under any circumstances fill an emergency prescription like this?
That's a great question. Colleen, do you have an answer to that question?
My inkling is that a pharmacy technician would not be able to do it without, you know, how do I say this? My understanding is that everything that's done in a pharmacy needs to be done under the supervision of a pharmacist. So, you know, while a pharmacy technician might actually be the one sort of filling the bottle, the decision about whether the drug was dispensed would have to be done with the authority and supervision of a licensed pharmacist. That's my understanding of how that would work. So I don't think you need to specify that. That's sort of within the scope of the license, as I understand it. I know that Ms. Betts, I think, is here. And maybe if there's any disagreement with what I said, she could raise her hand and be recognized on that particular point. But that's my understanding of how the licensing would work. It would be done with the oversight and supervision of a licensed pharmacist.
And Madam Chair, if I may.
Go ahead.
And that's what I read up on as well. But I've seen so many signs as I go into some of these pharmacies that, the pharmacist isn't on duty. And I know that doesn't excuse the practice. And I just want to make sure that we codify and make sure it's spelled out crystal clear that, yeah, this is an emergency refill or an emergency supply. You can't supersede the current statute. And it has to be the pharmacist, making sure that this is happening and not a technician. That's all.
I think that the adding in the language from Mr. Moran's proposed
judgment
C, where it talks about in the pharmacist's professional judgment, the medication is essential. I feel like that's pretty strong, because it's not just a record keeping piece, but like an actual judgment that has to be made in the moment. I mean, we could say something like which, decision cannot be delegated or something like that, but I don't know if that actually helps or that just makes the language more confusing. Representative Tepler, are you on the same topic here?
Yes, I am, and I'm agreeing with you, and I can't imagine with the language that you just stated, Senator Sanborn, that a pharmacy tech wouldn't insist on speaking to the pharmacist before dispensing the medication. And maybe that means waiting until after the pharmacist comes back from lunch. But I also hope that most pharmacies aren't operating to fill prescriptions that haven't already been vetted by a pharmacist unless a pharmacist is on duty. And I see that Amelia Arnold and Jerry Betts have their hands up, so I'll probably just let them really answer the question.
Yeah, I think it would be worthwhile to bring them in. I'm not a host at the moment, so I can't do that.
I'll do it. I will do it.
Thanks.
I'll bring them both in. That makes at the same
Yeah,
time.
that's fine.
Okay. Looks like Amelia's coming first, but let's see. I think they're both.
Good afternoon. I see you're in your car, but it has stopped. So that's a good sign. Thank you.
Yeah, I didn't quite make it back to the office before you called this bill up. So,
okay.
So I would just, and I'm sure Jerry Betts would say the same thing, is that technicians can't perform a final verification of a prescription, which would be, in my opinion, a hard stop of that they wouldn't be able to write this prescription. A few other reasons why I don't see that there could be loopholes around. So first, if a pharmacist is not on duty, the pharmacy cannot be open. So you can still have like some pickups while they are maybe eating their lunch. But if there's not a pharmacist in the building, the pharmacy cannot be open. So I think that's another stopgap. And then additionally, we're the ones that carry like the provider numbers, so the NPI numbers, and they work under it. So like pharmacy technicians cannot counsel patients. So there are a few different ways that I feel like there are many stopgaps there that would prevent a pharmacy technician from saying, oh yes, we're going to write this prescription again. The pharmacist has to physically, review and check in the computer those prescriptions before they leave the door. So.
Thanks. That's helpful reassurance, Ms. Arnold. Ms. Betts, do you have anything to add?
Good afternoon, Senator Sanborn, Representative Tepler, and members of the committee. I don't have anything to add. Ms. Arnold certainly was very clear in her analysis, but the pharmacy technician works under the supervision of a pharmacist at all times, and any prescriptions that are filled go through a final check by the pharmacist before it even gets to what we call the will call center, which is where we as patients go pick up our prescriptions. So there are checkpoints in balance, but the pharmacy technician can certainly prepare the medication that needs to be dispensed, but the pharmacist makes the judgment call on the filling of that prescription and does the final check of what has been completed by the pharmacy technician. I hope that helps.
Yeah, I think so. Representative Tepler.
I am moving on to a slightly different topic. Is that appropriate at this moment?
Sure. Yep, I think it is. And we need
yes.
Ms. Betts and Ms. Arnold, or should we leave them on the panel? Or
This piece is not related to Ms. Betts or Ms. Arnold, so.
Okay, I'm going to move them back to the attendee.
Thank them. I thank them
you.
very much for their help.
Yeah.
Very welcome. Thank you.
Thank you both. Representative Tepler, go ahead.
Thank you. So I have been notified by the representative of the Nurse Practitioners Association that we need to be cautious about using the language physician when referring to prescribers, and that we need to make sure we're saying prescriber rather than physician in various places in the bill, just so that NPs who have prescribed medications are included in the bill.
Yep, and I apologize. That was my shorthand. The actual text of Mr. Moran's proposed amendment, though, uses the word prescriber, and I just shorthanded it in the wrong way. So I apologize to all those important allied professional, or no, additional prescribers, additional medical professionals out there that have other titles other than physicians.
Yeah, it's practitioner is what the bill uses, and so that'll be consistent throughout. Practitioner who prescribes, I think. And I'll double check to see what. Yeah, I'll make sure that it conforms with how they're referred to in Title 32, which may be both prescriber and practitioner, but we'll clarify that.
Great, thank you, Colleen. That's a good point. All right. I think the last issue we need to tackle is the benzo issue. And unless there's any other issues on the table that anybody wants to talk about, I kind of wanted to put the benzo issue off to the last conversation here. So if there's another issue, all right, not seeing one, let's tackle that piece, which I'm pretty sure was what Mr. Moran wanted to talk about. So I will bring him in just to talk about that particular issue. Except I can't move anybody because I'm not a co-host.
It's coming.
Thanks. Now I'm a co-host. Excellent. Okay, Mr. Moran, can you weigh in for us on this issue of benzodiazepine and why you had added it as additional prohibited substance on your proposed amendment?
Yes, thank you, Madam Chair, and great question, Chair Tepler, on the seizure disorders and epilepsy and associated issues with that. You may not see in some of the other model language from other states, benzodiazepines, but one of the things that we've become aware of at the MMA over the last year is pretty widespread discussion about benzodiazepine misuse. To the point where even the Board of Licensure in Medicine is considering, or actually has decided to form a work group to take a look at prescribing patterns related to benzodiazepines. So, it's a great point. I'd love to take it back to the clinicians on our legislative committee to talk about what Chair Tepler mentioned. I wouldn't see a problem necessarily from our organization about including some sort of carve out in there. Benzo misuse among people with epilepsy has also recently been documented in some studies. So, at the end of the day, and I mean, Senator Brenner knows this, if let's say there is a carve out and somebody does get bridge medication for their epilepsy and the prescriber is notified, if there is a potential benzo misuse there, I mean, that'll be addressed between the patient and the prescriber, I would hope. So, I agree on behalf of the MMA that it's important to carve out those situations where it doesn't have to do with misuse, if that is a convoluted way of responding to your question. And can I ask a clarifying question about one of the amendments, Madam Chair?
Go ahead.
You had said something up to 30 days in original containers, but disseminating the smallest supply. So The amendment that we suggested or recommended was a 72-hour supply unless it comes in a package that's more than that. So is the parameter they can go up to 30 on anything, or am I misunderstanding your amendment?
The parameter is they could go up to 30 on anything, and it may be more than 30 if that was just one inhaler, for example.
Okay.
That's the smallest available package. That's the proposal. Okay.
Thanks.
Yep. And it was up to, so that the professional judgment of the pharmacist and the circumstances of an individual patient can be taken into account in the emergency dispensing. So that,
yeah, and again, that's another situation where, you know, the MMA would prefer 72 hours or something in that effect to a bridge, but at the same time, you know, that relationship between the physician or the provider, prescriber, and the patient, if that prescriber sees that they got a 30-day bridge gap, I'm sure that'll be discussed at, you know, the next appointment and talked about in that specific relationship. So although it's not what we suggested, it's certainly something that can be put up to the prescriber and the patient in the end.
thank you, Mr. Moran. Ms. Representative Malrano, go ahead.
Thank you, Madam Chair. I was just wondering if we can talk about this benzodiazepine issue a little bit more. And I don't know that I have the answers, but I will say I'm a little bit uncomfortable with excluding benzodiazepines for some conditions, but not for others. So, you know, if it's prescribed, and I heard what Mr. Moran said about possible overprescribing, things like that, or possible abuse at times. But what about, can I just put this out there? What about including benzodiazepines, but for a shorter amount of time, like 72 hours or 7 days, because it's a higher risk drug. But then we're not, because when we sort of say, oh, it's okay for folks who are subject to seizures to get it in an emergency fashion, why are we excluding other folks that are dealing with other perhaps mental health issues from getting it on an emergency basis? And if we do, okay, another question I would have as well, if you don't mind, would be in the other states that have passed this already, did they include or exclude benzodiazepines? How did they handle that? Because I'm not sure myself. Thank you.
Mr. Moran, do you want to tackle either of those questions?
Yeah, thank you, Madam Chair. To her second, to Representative Malrano's second point, as I mentioned in the beginning, I couldn't find any other examples where benzos were excluded from the statute on that, but in discussions with some of the clinicians, there's just a lot of debate going on among the physician community about benzodiazepine prescriptions, and I thought it would be proactive to at least discuss it and put it in a recommendation. But you know, I tend to agree with Representative Malrano on but what about this, but what about not that? I mean, now at the end of the day, this doesn't affect the prescribing decisions between our members, the physician and the patient, but you know, we have a tendency to not want to statutory define, you know, you can do this, but you can't do that, or in this case. So, I mean, I think that's up to you, the committee. Now that, you know, we've made you aware, so to speak, for lack of a better phrase, that benzodiazepines are a concern among the physician community. Some in the physician community, I mean, that's a committee decision from this point to and having to do more with bridge than prescribing patterns.
Understood. Okay, I think that there's a bunch of hands up about benzos, and I'm going to bring Ms. Arnold in as well so that we have kind of the other perspective on this as we continue to discuss this. So let me bring her back over. Good afternoon again. And so next, I think I saw Senator Brenner's hand first. Go ahead, Senator Brenner.
Thank you, Madam Chair. I think that from my perspective speaking as a clinician, I would rather, if I had a patient who I'd prescribed benzos to, I'd rather have my patient be able to get the medication and not be subjected to having a carve out that's specific just for seizure disorders. My sense is that if we want to manage benzos as a medication group, as a drug group, we should be doing it on the individual patient to provider basis, and we shouldn't be using this bill and this statute and changing this statute as a way to manage that issue. It doesn't seem like it quite gets to the real issue, which is that maybe these patients should be on different medications and we should be rethinking what we're prescribing. It doesn't quite address that issue. And so I'm not sure that I want to exclude benzos from what could be what you could get in an emergency situation like this. So I'm of the mindset that I would rather it not be excluded, and I don't really want an exception or carve out.
Okay, Representative Tepler.
I really wanted to hear from our clinicians to hear what their thoughts were. So I appreciate that, Senator Brenner, and I hope that Representative Evans will weigh in as well. I know that there has been concern about abuse of benzodiazepine for a while, but I guess the question in my mind is, who is prescribing it as a daily medication and for what conditions? My understanding was that many times it's prescribed as a sort of take it when you are about to have a panic attack or have severe anxiety, as a mental health medication. And I guess I'm wondering who really needs that emergency supply of it. And I think Stacy answered that somewhat, but I'm sorry, Senator Brenner answered that somewhat. But I'd like to hear from Representative Evans and Representative Matheson, who are all clinicians. Thank you.
Representative Matheson has her hand up next.
Thank you, Madam Chair. I'm not sure that I'm going to be able to answer specifically your question, Representative Tepler, but I do think that we tend to carve out mental health from emergency situations here, and I feel very uncomfortable about that. So I would have to agree with Senator Brenner that I really don't feel comfortable carving this out of the bill. So that's where I stand for the
Okay, Representative Arford, your hand just went down, but I think you wanted, are you good? Jumping all around. Okay, Representative Evans, go ahead.
Thank you, Madam Chair. I am of the opinion that that decision should be made between the physician and the patient. I'm not in favor of a carve out for benzodiazepines. There's a whole class of medications that could fall under that same category. And once you start carving out one, you're gonna have to carve out all of them. So I think that that's a step too far. So I would agree with Senator Brenner that we should back off of this one.
Okay, Representative, I just made you a representative, Ms. Arnold, go ahead.
I just wanted to put the perspective out there without saying, like, I think there's some compelling arguments for both sides of this, but a pharmacist will not always have access to exactly what that patient is using the medication for. So quite often we might know, and we certainly can see if it's, take one PRN or as needed at the onset of anxiety attack. But if it's like a daily use or something, we may not know particularly what that medication is being used for. You know, I'd like to think that the physicians and nurse practitioners and PAs and other prescribers hopefully would have understand, like, where I would never personally as a pharmacist just give a blanket like, yes, I'm going to use this every day, every time someone's out of refills. So I think if I put the lens of specifically benzodiazepines on and think about experiences I have, I could certainly see some that would be really compelling to want to use this mechanism. And then I could see others where it's like, you know, you take it to help you sleep at night. Is that an emergency or not? Like, you know, there's questions there, kind of both sides. It's not an easy thing to do. I can kind of tell you for some of these harder ones right now, like, I don't think you'll find it's normal for a pharmacist to forward a few benzodiazepines to someone. I think more often than not, if we view it as a true emergency, you're looking at like paging the on-call doctor at this point to get that sort of thing done. So I just want to make sure that, you know, kind of let you know what's going on now. But if you start to go by diagnosis code, you will absolutely put pharmacists and physicians and nurse practitioners and PAs into areas that we don't have all of the information, and that could cause some issues for everyone involved.
Okay. That's helpful context. Definitely. Okay. I think the consensus, it feels like, although we certainly haven't heard from every member of the committee, is to to change the verbal amendment that I had suggested to take the word benzodiazepine out entirely. And then it would just have controlled substances, including opioids, would be the language that would be in that provision of the bill. So I'm seeing some nods. I'm not seeing any electronic hands go up. Is there anyone who wants to further discuss or go a different direction with that? Okay. All right, then I'm going to once again thank Mr. Morin and Ms. Arnold for joining us. And I'm going to move you back to be panelists, to be attendees, I should say. Okay. So we have a motion that I think everybody knows what it is, although it's got a bunch of pieces. They are all kind of written in various places in front of us somewhere. I don't know if there was a second. Seconded by Representative Matheson. Is there further discussion on the motion? All right, seeing no electronic hands, wait a second. I do not see any other hands. So the motion is ought to pass as amended, and I'll have the clerk call a roll.
Thank you. Senator Sanborn.
Yes.
Senator Sanborn, yes. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Stewart. Senator Stewart, absent. Representative Arford.
Yes.
Representative Arford, yes. Representative Bleier.
Yes.
Representative Bleier, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Malorano.
Yes.
Representative Malorano, yes. Representative Morris.
Yes.
Representative Morris, yes. 11 members of the committee having voted in the affirmative and 0 in the negative.
Great. Thank you very much, Ms. Caford. And so next we will go to our work session on LD 1783, and I'll have Colleen present her bill analysis for us.
Sorry about that. I just deleted it. Get it back. There we go. I don't have two screens today, so I'm having a
Oh,
hard time.
no.
Usually I have two screens. So this is LB 1783. The bill as drafted requires health insurance carriers and their pharmacy benefit managers to include cost sharing amounts paid on behalf of an insured when calculating the insured's contribution to any out-of-pocket maximum, deductible, or copayment when a drug does not have an alternative equivalent or was obtained through prior authorization, a step therapy override exception, or an exception or appeals process. The bill's requirements apply to prescription drug benefits provided pursuant to a policy or contract issued on or after January 1 of 2023. I did share with you the current requirements in law which regulate health plans that provide prescription drug benefits. Committee members who have served in the 129th will recall that you did a lot of work putting into place statutory regulations for pharmacy benefit managers and for prescription drug benefits. And LD 1783 adds a provision to that chapter specifically with regard to these what you heard at the public hearing are called sort of copay accumulator programs that carriers use. So it would prohibit that and then instead require carriers to count any cost sharing amounts that are paid on behalf of an insured through these programs towards their out-of-pocket maximum and annual deductibles. I think you'd asked at the public hearing for sort of a visual to kind of give you a sense of sort of how coupons work. And I was able to find this sort of visual chart, which kind of shows, gives you some idea of how the coupons specifically would work if that's the situation that a consumer finds themselves in. The coupon is issued by the manufacturer. It goes to the consumer, and the consumer can use the benefit of that coupon or any additional out-of-pocket costs that they need to pay that they pay at the retail in the retail setting for that particular drug. This also shows you sort of the flip side. We've talked about it, a number of other issues for rebating as well, how that works. There were, for this bill too, you got a number of pieces of written testimony that were submitted following the hearing on this bill that have now been uploaded to the electronic LD file. So I just wanted to note that for you if you're interested in taking a look at any of that further. But in terms of the issues that you might think about with regard to this bill, sort of the proponent testimony that you received talked about the financial impact on patients of these programs when they are required to fulfill the deductible and meet out-of-pocket maximums sort of a second time in their view after financial assistance from coupons or other financial assistance mechanisms that are provided by drug manufacturers are no longer available to them. So you did receive a lot of testimony from patient advocates and other groups indicating that this, without the bill, the current practice, if it's used, increases their out-of-pocket costs and does mean it will take patients longer to meet their annual deductibles. On the other, you've also should consider whether the use of these programs sort of negate the benefit overall of these financial assistance programs or the use of coupons to consumers and how that impacts them. But you also had testimony from those who provided input either in opposition or neither for nor against the bill, asking you to think about the extent to which the use of coupons increases the overall cost of prescription drugs. And the carriers use programs like these to help manage costs. And the bill, if it moves forward, might increase overall costs and also might impact the actuarial value of health plans by shifting sort of the responsibility for cost sharing from consumers back to carriers. It was also suggested that the bill might have an impact on overall premium costs, not only shifting costs to the carrier, but also in the case of employer plans, maybe shifting those costs back onto the employer as the policyholder. Some of the testimony you received too from carriers question whether this might impact small employer choices about how they provide coverage and potentially move some small employers who have fully insured plans, might make them more interested in moving to self-insured or experience rated plans. You received some testimony finally that I wanted to note that came in written form from the Health Purchaser Alliance, which represents sort of employer sponsors of health plans and other payers. They suggested the committee consider the bill along with recommendations or strategies that might be included in the annual report that's expected soon from the Maine Prescription Drug Affordability Board, and suggested you might considering that in that context. And then lastly, I wanted to note some additional written comment and testimony that was submitted following the hearing by the Maine Association of Health Plans, asking that the committee consider further amendments to the bill. They did suggest that the committee might consider banning the use of coupons outright. They are prohibited under the federal Medicare and Medicaid programs, and 2 states, Connecticut and Massachusetts, have taken action to ban their use. If the committee is interested in alternatively, I think if the committee is interested in moving forward with the bill as it's outlined, the Maine Association of Health Plans suggested the committee consider additional amendments, adding exceptions to the ban on using these programs if there is a covered interchangeable biosimilar drug, or if there's a covered drug at the same therapeutic class that may be preferred under the plan's formulary. Adding a requirement that any third party that pays any amount on behalf of an enrollee for a covered prescription drug must offer the assistance for the full plan year, that they must notify the enrollee prior to an open enrollment period if the financial assistance will be discontinued in a subsequent plan year, and also require that that third party may not condition the assistance or enrollment in a health plan or type of health plan to the extent permitted under federal law. They also suggested that you might consider some additional reporting requirements or data collection to MHDO or the Prescription Drug Affordability Board about the use of coupons and the use of these programs. You also received some written comment from the Maine Bankers Association and the Maine Chamber of Commerce, raising concerns about how this might impact high deductible health plans that are associated with health savings accounts. There are some federal Internal Revenue Service regulations that impact sort of how payment for preventive care and payments like this are presented. And so they were concerned that if the bill moves forward as drafted, it might disqualify a health insurance plan from being a high deductible health plan and prohibit or make the consumer ineligible to contribute to their health savings account. Their testimony suggested that the committee provide an exception for plans offered for use with an HSA. You have talked about this issue before in the context of the consideration of the Made for Maine Coverage Act, LD 2007 from the 129th legislature. And there have been instances where you've put similar language, sort of exception language in current law that relates to this question about requiring cost sharing to be paid on behalf of an enrollee or eliminating cost sharing, potentially interfering with the federal regulations for health savings accounts. So the Bankers Association had suggested some language, but I also included for you as an example, the language that's in current law as it relates to a prohibition on cost sharing for primary care and behavioral health visits in a plan year. You might recall that there are requirements that eliminate cost sharing for up to 3 visits in a plan year for these services. And so the current law accepts or provides an exception that says that the subsection doesn't apply to a plan offered for use with the health savings account unless the Federal Internal Revenue Service determines that the benefits required by this section are permissible benefits in a high deductible health plan as defined in the federal regulations. So if you do move forward with the bill and you think this is a valid concern, that's an example of how you could clarify that, how the bill or the provisions of the bill would relate to a high deductible health plan and the potential impact on HSAs. We talked before about the scope of our insurance laws and how far they can go, so I won't mention that again. I did provide some examples of other state laws. I think you've heard in testimony, and the National Conference of State Legislatures has a lot of information about prescription drug laws in other states. There are 12 states that have enacted laws similar to LD 1783. Puerto Rico has also taken steps to enact legislation there. So I wanted to note that for you. And we don't yet have the fiscal information from the Office of Fiscal and Program Review on the bill. I'll stop there, and I'm happy to answer any questions or pull up any additional information you might need.
Thanks, Colleen. I'm just going to let the committee know and also drop into the chat a copy of the NCOIL model, which I recently discovered has just been adopted by the National Council of Insurance Legislators. And it was just adopted in the middle of November. So that's why I had missed it in the past. But I'm going to just drop a link to it into our chat. I'm going to note that it follows the text of the bill that has been proposed largely, but with a couple of exceptions that I think are really helpful. And one is that it includes the HSA language largely as Colleen just described it, except that it's a bit more nuanced, I think, than what we did with the exception there, because it allows for those coupons to still work in any kind of way that they work under federal law in association with a high deductible plan. So in other words, they can still work if you've already satisfied your deductible, or with regard to preventative care medications for which they would be allowed under federal law. So it gets into the nitty-gritty details, and so that language is already there. So I'm gonna just direct the committee's attention toward that formulation for the HSA language, and I think that the NCOIL folks have done the heavy lifting for us largely on that. The other piece that's in the NCOIL model that I wanted to just bring to the committee's attention, and that I think is really pro-consumer and would be an improvement on my bill, is that there's a second piece that requires that the person or the company that pays any amount on behalf of the enrollee for a covered prescription drug has to notify the enrollee prior to the acceptance of the financial assistance of the total amount of assistance that's going to be available and the duration for which it'll be available, so that you know if you're getting a coupon, how long you're going to get a coupon for. And I think that's really pro-consumer. And forces these manufacturers to have to be really transparent and upfront about this. And it also, there's a provision here that makes it so the manufacturer can't condition those coupons on your enrollment in a particular health plan or type of health plan to the extent allowed by federal law. So so this would allow for less market manipulation, I would say, and more transparency. So it's in the NCOIL Act. I think it's pro-consumer, and I just wanted to suggest that we go with that formulation and include those provisions. The NCOIL Act also includes that generic equivalent exception that's already in the bill, and so it would retain that. So I just wanted to get all of that information out there because I did discover the NCOIL model after public hearing when I was doing some more research on other states. And so at this point, I'll open it up for questions for Colleen. And I don't see any. So I would open it up for just general committee discussion on the bill. Is there a motion? Representative Morris.
Yes, thank you, Madam Chair. I'm just reading through some of the stuff on the NC. It seems to address, I think, a lot of the issues that were raised at the public hearing and that were a concern. I'm not sure if maybe it makes sense to look it over and maybe see it in a main statute language before we vote on it, but I'll leave that to the committee.
Sure, I'd be happy to take the time to do that. Senator Brenner?
Is it possible that we could trust Colleen to put it into main statute language? And then if folks aren't comfortable with it, we could reconsider on language review?
I would be amenable to that, absolutely.
Okay.
Then I'm happy to make a motion.
Thanks, Senator Brenner. Go ahead.
I make a motion to pass as amended.
Second.
Okay, great. Is there further discussion? All right, I don't see any. So with that, I'll ask our clerk to call the roll.
Thank you. Senator Sanborn.
Yes.
Senator Sanborn, yes. Senator Brenner.
Yes.
Senator Brenner, yes. Senator Stewart. Senator Stewart, absent. Representative Tepler.
Yes.
Representative Tepler, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Bleier.
Yes.
Representative Bleier, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Malavano.
Yes.
Representative Malavano, yes. Representative Morris.
Yes.
Representative Morris, yes. 11 members of the committee having voted in affirmative and 0 in the negative.
Great, thank you. All right, so thank you, Senator Brenner, for helping us move things along. I appreciate the assist. And we will move things right along and pick up LD 1798. And on this bill, we have had a prior work session on this bill. And so there's actually a drafted amendment in our committee file, and there's a motion on the table ought to pass as amended. There was a request that we wait until it was drafted so that we could come back to it. But I actually think that there's one nuance in the draft that I wanted to ask Colleen about. Colleen, in the cross references in the draft, because this is in several different sections of the statute, the definition of dependent child is actually different in the cross references in the different subsections. Some of the definitions of dependent child are an old version of the definition, like a pre-ACA version that says 19 as the actual definition of what a child is, which would be in conflict with the intention of this bill. So I was wondering if you had a good suggestion for how we should clean that up.
I was just looking at it quickly. I think I think that the way to clean it up is just to refer to the definition that works. It doesn't necessarily have to be within the same
subsection.
You know what I mean, subsection or close to it. So we can just replace it with the one that works if it's sort of referring to the old one. I mean, it is a little bit of a kind of a statutory construction because we're referring to sort of treating someone as a dependent child who is statutorily, that's a statutory term, but it's sort of a fiction, in a way, because they are going to be older than that. But I can make sure that I go through and clarify that we're referring to the right definition. And, even if the cross-reference is to, another chapter, for instance, and we're in the individual insurance, it'll work.
Okay, great. So we'll clean up those cross-references, and I will just say that that change would be incorporated into the motion that we have pending. Sure. Is there any further discussion on the amendment as drafted? Representative Brooks?
I just had a thought with this. Has to do with definition of child. Especially with our global pandemic, things have shifted, to say the least. So that one would think of a situation where there could be anybody that is suffering health consequences or otherwise job loss, financial difficulties, so that it's important we stick together as a community. So getting to the question and point, I'm thinking that instead of trying to calculate how long the state of emergency is and when it will resolve, to kind of have like more of an open-ended thing at this point in time. Like instead of saying dependent child, more say just child.
Okay.
I know the ACA does one definition, so I don't know. That's just a thought.
Yeah, I think we've clarified that it is a disabled child of the person that's covered by the plan. And that's the definition that Colleen will go back and pluck from the individual context to make sure that it's consistent in the group context. So I think we're all on the same page with that regard. Great. Okay. Is there any further discussion on this bill? All right, now, Representative Morris, go ahead.
Yes, thank you, Madam Chair. I think just had some, we want to make sure that what we're trying to do is what we're intending to do, and we don't have any unintended consequences with the language. And I think as I understood it originally, what we're trying to do is make sure we cover the gaps in coverage where others, where they need to be filled in as it relates to these, somebody with a disability, ensuring that they have access to the comprehensive care that they need. And we're not getting too big of casting too wide of a net to where I think that my biggest concern I would start with is requiring to now cover something that had not been anticipated, that they have no way to plan for, no way to underwrite for with an insurance. A situation like such as myself, I passed the age of 26 a long time ago. Well, maybe not a long time ago, but 13 years ago anyway. My parents, my mother still has private insurance. Obviously, they're not anticipating having to cover something like this, even if it may not, but if something like I could get sideswiped tomorrow. Now, currently I have insurance through the legislature, and I guess what I want to make sure that we're trying to ensure is that if the person currently has insurance, such as myself, or in that situation, that it would be the expectation that their current insurer would still be responsible. I don't know if that makes, if what I'm trying to say makes sense.
I think it does, Representative Morris, and I think it's actually already kind of baked into the context of the bill, because the bill requires an offer of coverage. It doesn't require coverage. So in order for you to be covered, you would have to be enrolled first. And so all this does is if you were a dependent child with a disability who was whatever age that you are, and your mother chose to enroll you, the insurance company wouldn't be able to say, no, you can't enroll him, he's too old. That wouldn't be possible. But the insurance company would know that you were enrolled before they had to pay anything. And your mother would have to pay premiums based on having an additional person on an additional member of the family, or however the premium is calculated.
And I guess that's also brings up another question, is in that instance, we've talked a lot about the family glitch. How does this fit into that equation as well? Is because that's another thing that I thought of over the weekend, that if there's a scenario, because I do understand the point of what we're trying to do here, because there are certain private coverage would be better in certain instances, but it's also going to be more expensive for that premium holder. And if we're in a scenario where that offer of coverage is made somehow, and the person says, well, we can't afford that, will it impact their ability to get a main care or some sort of subsidy, thus creating this, triggering that glitch?
Yeah, that's a good question. I think for one, just to answer one piece of it, the family glitch only applies to ACA subsidies. It doesn't apply to main care. So it wouldn't be relevant for the issue of main care at all. It could be relevant to the issue of ACA subsidies, but I'm not sure that it is. I somehow feel like it's not, but I don't know if Colleen has any ideas, or anyone in the audience might know.
Most of the time when we hear about the family glitch, it applies to a marital situation, I think. So I'm not altogether sure what the impact might be in this situation, where you might be counting an income of a limited income of a dependent child. Because remember, one of the qualifying conditions here is that the person who you're enrolling, their disability make them sort of incapable of self-sustaining employment as a sort of an additional condition of their qualifying for coverage under this provision. So that's what I would offer there about my thoughts on the potential glitch. And again, it goes, as Senator Sanborn said, it would go to someone's ability to qualify for an advanced premium tax credit to help pay the premium, as opposed to sort of qualifying for coverage, underlying coverage.
Mm-hmm. Representative Tepler.
Yeah, I wanted to address a little of the concerns that Representative Morris had as well, and think about them out loud a little bit. So let's say you're in that terrible car accident where you get sideswiped, and as a result, you have a disability that doesn't enable you to work anymore. As you process through that, the insurance that you held at the time of the accident is responsible for covering you in that accident and your recovery from that accident. But then when you're no longer employed, because the conditions here we're talking about not employed, then you don't have insurance anymore. And perhaps if you're not able to work as well, your parent would want to insure you under their policy by applying to have you covered under this clause. And that would be after you were already at a point where you knew you couldn't work anymore. Basically all the payments that were involved with the injury as a result of the accident would have been taken care of. And then the other family glitch issue is a little more complicated, but your parent might not be eligible for ACA subsidies themselves if their employer offers coverage to them. But that's not the same thing as whether or not you are eligible for subsidies under the ACA, which probably you would apply for as an individual and not as part of a family.
I thank you, Madam Chair. I appreciate all those answers. Like I said, I think, we all support the aims and the goals of this, just wanting to make sure, we don't set up a situation of some unintended consequence that we weren't intending to do. Again, I don't think this is going to be something that's going to be a wide issue, widely used. And I think just hopefully that this stays with the original intent of just trying to fill those gaps in coverage is really, and I know that the 100 scenarios that come up, and those are some other questions I thought of over the weekend. I'm certainly prepared to support this today, but it may be something that in the future we'll have to really, want to follow and see if it may be something that's worth amending to see if we can improve it in any way. That's my only concerns.
Thank you, Representative Morris. Are there any additional points of discussion on this motion? Ms. Awesomenfort has her hand up. I'm going to bring her in, find out what she wants to give us as her comment. Good afternoon, Ms. Awesomenfort. Is there something that we have missed?
No, I just wanted to raise.
Oh, you've frozen. Hopefully you'll unfreeze.
Ms.
Awesomenfort, can you start over? You froze and then we couldn't hear you. So start over and I think we can hear you now.
Okay, is that better? Or should I turn off?
Turn off your video because your video is frozen again.
Is that better?
Yes.
Okay. Thank you, Senator Sanborn and Representative Tepler and members of the committee. I do have concerns with the emergency preamble.
Okay, we lost right after you said emergency preamble, but I think I got the gist of it. So we'll talk about the emergency preamble with Colleen, and we appreciate you getting those words in before you broke up. I'm going to move you back to the attendee portion, but we'll turn our attention to that issue. All right. Colleen, do we have an emergency preamble on this? We do.
There is an emergency preamble on it. And my recollection when you talked about it last week was that you felt that because it was a mandatory offer of coverage that you didn't feel like you needed to put a specific application date on there. Yeah. But I did raise it as a question as to whether or not how you wanted to address that issue. But I don't believe it was part of your motion. I think you maintained the preamble in the ought to pass as amended motion. So that the draft that I prepared for you keeps the emergency.
Understood. How do people feel about this? I think we heard testimony that every insurance company already makes this offer of coverage, but they may use slightly different language in doing it at this point. And we're going to have people turning 26 who have disabilities throughout the rest of this year and so forth. What is everybody's feeling on it? And if you could raise your electronic hand if you have a thought on it. Representative Brooks.
My thought is that it is beyond an emergency. And that being said, if we make a change with the idea that we're going to work towards having everybody covered on this standpoint, it's kind of the implementation type issue, and that's more important. It's important, but as long as we understand there's an emergency.
Representative Morris, what are your thoughts on the emergency?
I think it would make sense to strip the emergency off at this point. I don't know that, I think that there needs to be some time to rate for this specific scenario as well. I know that many of them are covering it, but we're also broadening it a little bit from where the original bill was. So it probably would make sense to take the emergency off and, and push out the application date, only because of some of the other pieces that we've added at this point.
Okay. Representative Tepler, go ahead.
Thank you, Madam Chair. I understand the concern on the part of insurers that they need time to prepare the rates, they need time to prepare what the offer of coverage will look like. But I'm also concerned that pushing it back to an effective date that will happen 90 days after we finally end this session, and we have no idea when that will be, means that there are a set of people turning 26 with disabilities who may find themselves without insurance for that period of time. And that does concern me. I'm wondering if there's a way we can build some retroactivity in for coverage, or I don't know, something that would enable those people to get covered. That's my concern.
Representative Morris.
All right, let me sure. I wonder if it would make sense if with the people that are currently that are going to be turning 26, there's a way to kind of do this two ways, to where they're in that position, someone who is in that position, to make it an emergency and allow it to happen for them. I mean, particularly since insurance companies are already doing it. And then if it makes sense to have, whether it be we have to do a second bill, or I don't know exactly how you do it, but sort of, because I think, like I said, where we're broadening the scope of this beyond what the original bill that was intended, it would be hard, because again, of the scenario that you laid out, someone who's maybe 35 who tomorrow has an event that would trigger this, and there was no way to plan for that. There's no way to have planned for that in advance, versus the person that's going to be turning 26 in this interim time frame that's already been planned for by the insurance companies and so forth. Whereas this could, even if there may be only a handful of scenarios, it hasn't been planned for. Now you're asking them to implement it. They just have no way there's just no way for it to be dealt with in that sense. So I wonder if there's a way to do an emergency for certain to cover the situation as the bill was originally intended. And then figure out another way to deal with, some of the more broader things that we've added.
Senator Brenner.
Thank you, Madam Chair. I feel like we're kind of splitting hairs here. If this is already something that for the most part, insurance companies are covering, and we're talking about expanding it to in a moderate way, you know, the last thing I want is for one of my constituents to be caught in a situation where they are that person that gets sideswiped and we didn't put an emergency clause on when we could have. And, you know, then we're sitting there fighting for some sort of retroactivity and fixing a bill when we're sitting here right now with the capacity to say, yeah, this is the right thing to do. And this is, you know, this is a good piece of legislation, and we want to make sure that we extend this coverage. And honestly, there might not be anybody that takes us up on it, but if there is someone that needs it, wouldn't it be nice to say, gee, I'm really glad that we made that decision? And so I feel like we should leave the emergency clause on there. I just don't think it's going to be that big of a burden to the insurance companies that they can't absorb it.
Representative, oh, okay. Representative Arford.
Yes, thank you for recognizing. I'm sorry I was unmuted for a second, but I agree with Senator Brenner that we should go forward with this bill as the amendment is currently drafted. I think we've discussed it at great length, and for all the reasons that we have stated, we should go forward with it. And I'm willing to make a motion if that's the sense of our committee.
Okay. We have a motion already on the table, and it already has an emergency clause. I'm going to suggest that we have a corner caucus, and then we can come back and we'll figure out where to go from there. We'll be back in about 5 minutes. All right. And then can you make me a co-host again? I don't know if I'll need it, but. Great, thank you. Okay. So let's see. Some folks are still rejoining, so I'll give people a minute.
Who is Rio?
It's Gina.
Oh.
I think her panelist invite had her name spelled wrong or something. I'm not really sure. This is a typo. She fixed it the last time she was here. Yeah, she just
There
fixed
we go.
I'm gonna wait for our colleagues from the other caucus to come back. Okay. Welcome back, everybody. I am going to propose that we amend the motion to strip out the emergency clause. And otherwise it would be just the same as what we had discussed. Is there a second for the amendment? Seconded by Representative Evans. So we have an ought to pass as amended motion on the table. Is there any discussion? All right, seeing none, I'll have the clerk call the roll.
Thank you. Senator Sanborn.
Yes.
Senator Sanborn, yes. Senator Brenner.
Yes.
Senator Brenner, yes. Senator Stewart. Representative Tepler.
Yes.
Representative Tepler, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Blyer.
Yes.
Representative Blyer, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Representative Connor.
My apologies. Yes.
Representative Connor, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Milano.
Yes.
Representative Milano, yes. Representative Morris.
Yes.
Representative Morris, yes. 11 members of the committee having voted in affirmative and 0 in the negative.
All right, thanks very much. And I think that actually concludes our work for the afternoon unanimously. Woohoo, back to HCIFS style. I love it. Good work, everyone. And we are in session tomorrow. And then on Thursday, we have public hearings. Is that right?
Yes,
Yeah.
a bunch, 6 bills scheduled for public hearing on Thursday.
Bill scheduled for public hearing on Thursday, starting at 10 a.m. So we will see you all for that. Edna and Colleen, will you follow up with the folks who were absent or unable to vote today?
Yes, I
Okay.
will.
We
Mhm.
will.
Wonderful. All right. I'll see many of you in person tomorrow.
Hope to
Thanks,
see a lot of you in person tomorrow.
Thank you,
Yeah.
everyone. I
Thank
think we
you.
did some really good work today. I'm really pleased. Thank you.
Thanks, everybody.
Thanks, guys.
Bye now.
Bye.
Take care.
And I'll give you a call in a little bit. We can go over some of these things. I can't hear you. I'll just call you. I'll call you.
Yes, just to make
I'll-
sure mine's the same.
Yep, I'll give you a call.